So diagnostics are the tools we have to try to figure out what's wrong with the patient, to figure out what we need to do to help and treat them. And so this is going to help us hone in on figuring out what's wrong with this patient so that we can provide the best care for them. So we're going to dive into the normal vital signs, and we're going to give you a rundown of how to obtain these and then also what these mean with these patients. Okay, so we're not going over just vital signs today. We're gonna be talking a little bit more about a broader spectrum of diagnostics. So first off, we're gonna look at the 3 primary vital signs, and then we've got some secondary diagnostic tools that we'll use as well. So the 3 things we wanna know on these patients when we're assessing them are pulse rate, respiratory rate, and blood pressure. Secondarily to that, then we will assess temperature, pupils, blood glucose if you have a way to assess that, and then also breath sounds. So when we're treating these patients or assessing these patients, we want to start with massive hemorrhage, major bleeding, severe life threats first. Then we work through the ABCs, airway, breathing, and circulation. We want to make sure that we have these primary things taken care of that could kill this patient in the next several seconds to minutes before we move further down into the assessment. Once those are taken care of, now we can start getting diagnostics, vital signs, and start doing further care for this patient. So once we get to the vitals portion of our assessment, we're going to take a look at pulse, respirations, and blood pressure. Okay, the first vital sign we're going to talk about is pulse. So your pulse rate is how many times your heart beats in 1 minute. So when we're going through our ABCs, airway, breathing, circulation, we're going to do a quick pulse check. We want to know if it's fast or slow, and we want to know, is it a bounding pulse or is it a thready pulse, meaning good blood pressure, bad blood pressure. So when we are assessing for this, we're not getting an actual number tied to that. We're just going to feel and go, okay, it's a rapid pulse and I've got a good pulse present in the radial artery, so I know that they've got a decent blood pressure, and we move on. Then later, when we're taking a good set of vitals, we're actually going to count that pulse and figure out exactly what that rate is rather than just guessing slow or fast. So this, when we are assessing for a pulse, we're going to check a radial pulse on most adults, and we'll check a brachial pulse on pediatrics. The reason that we check a brachial pulse on pediatrics is because there is they don't have as big of arteries as adults, so it's going to be much harder to feel for that pulse on a small wrist of a baby or a pediatric. So for infants, babies, toddlers, we're going to check for a brachial pulse by reaching right up under the bicep and feel for a pulse here. That's a larger artery. For adults, we're going to feel for a radial pulse. So the radial pulse is going to be right here on the thumb side of your wrist. You're going to stick 2 fingers right here in a groove between these tendons in the middle of the wrist and this bone that comes from your thumb. Feel right up in there. Use your middle 2 fingers. If you use your thumb, you may be able to feel your own pulse. And so if you are checking a pulse on someone that does not have a pulse and you're all amped up and you have a lot of adrenaline pumping, you may put your thumb there and you may actually be able to feel your own pulse bounding in your thumb. So there's less arteries in your fingertips of your middle fingers. So I like to use my middle 2 fingers to assess for that pulse. Feel for about 10 seconds, see if you can feel that pulse there, move it around a little bit. This is a good thing to practice on other people because everyone's anatomy is going to be a little different. So you just need to get really comfortable with being able to grab a wrist, know right where to go, feel for that pulse, and be able to count that pulse rate. Now, as we count this pulse rate, we're going to use a stopwatch or a timer on your phone or something, and you're going to want to count how many beats you get in 15 seconds, 30 seconds, or 60 seconds. Counting to 60 seconds is going to be more accurate. But if you count to 15 or 30 seconds, then 15 seconds, you multiply that number times 4. If you count to 30 seconds, you multiply that number times 2, and that gives you the total beats per minute for this patient. Now, normal beats per minute for an adult would be 60 to 100. Now, if someone is outside of the 60 to 100 beats per minute range, there could be something wrong with this patient, or there could be some other reason why they are like that. If you go running, you take off running, you sprint a mile, you come back, I guarantee you your heart rate's going to be above 100. There's nothing wrong with you. That's just your body compensating for something, and that compensation is decreased demand for oxygen, needing to offload some of that lactic acid that's building up to be able to get that out. So there's a demand that causes that heart to beat faster, but there's not necessarily anything wrong with you that the body is having to compensate for. So knowing a little bit of history about these patients and knowing these vital signs will help clue you in as to what's wrong with these patients. Okay, so the next vital sign we're going to come to is respirations. That's your breathing rate. How many times does your patient breathe in a minute? So when we go through our ABCs, airway, breathing, circulation, we come to the patient, we assess for breathing. We want to know, are they breathing? Are they breathing adequately? And do we need to do anything to assist that breathing or take over that breathing with a BVM or something like that? We're not actually going to count respirations and take the time to get an accurate number on that. That's more of a too fast, too slow, what do we do about it? And then we move on. Then later when we come to our vitals again, we're going to actually get an accurate number. We're going to document that, and then we can use that number to trend them as time progresses to figure out, is their breathing increasing, slowing, changing, what's the differences? Okay, so when I'm going to count respirations, what I like to do is I will feel for a patient's radial pulse, and I will tell the patient, hey, I'm going to go ahead and take some vitals from you, so I'm just going to feel for your pulse for a minute. Just try to sit real still for a second so I can get a good pulse. And then what I'll do is for 30 seconds, I will start to count their respirations. I'm going to watch their chest, look for chest rise and fall, and count the respirations for the first 30 seconds. If they breathe 10 times in that 30 seconds, I double that, and their respiration rate is about 20 breaths a minute. Then I take the next 30 seconds and I count their pulse while counting. And so if their pulse rate is now at 40 in that remaining 30 seconds, now I've got a breathing rate of 20 a minute, and I've got a pulse rate of 80 a minute. Takes 60 seconds and I've got both those numbers just from looking at a watch or a stopwatch or a timer on your phone or something like that. So that is the method I use. If you tell a patient, hey, just breathe normally for a minute, I'm going to count your breathing, what do? Well, now they're very aware of how they're breathing, and they're going to sit there, and it's not going to be an accurate number. So make sure that you are kind of nonchalant about it, assess their breathing. Now, if your patient's unresponsive, it makes it a little easier for counting the breathing, right? You just count breaths a minute, do it at 30 seconds, double that, and that's your breaths a minute. So that's your respirations. It's pretty simple. How many times in a minute are they breathing in and out? So the third diagnostic we're going to look at is blood pressure. Now, let's talk about what blood pressure actually is. So you have veins and arteries in your body, and they're carrying blood out to cells, back to the heart, through the lungs, and they're carrying this blood all around your body. Now, that blood is propelled by the heart. The heart is the pump of this system. So when the heart beats, there's a spike in pressure as it propels that blood through the vessels. And then as the heart releases and now refills with blood, the pressures gradually come back down to a baseline before that heart beats again and spikes the pressure. So you get these waves and valleys, or mountains and valleys. So that peak of the mountain and the base of the valley are those two pressures that we want to look at. What is the pressure when it's at its highest, when the heart's beating? And as the heart relaxes and it comes back down to a baseline pressure, what is that baseline pressure? So we get two pressures when we take a blood pressure. We call the top one systolic, and we call the bottom one diastolic. And we write these as one number with a line over the second number, almost like a fraction. So we would call this something like 120 over 80. That's a pretty normal blood pressure. So I take a blood pressure, I figure out what the high number and the low number is, I come up with 120, I come up with 80, I write it like this, and then that is what I call my blood pressure. Okay, so there's three main ways we can assess blood pressure. The first way is using a blood pressure cuff and a stethoscope. This is the most common way. This is the way you should be doing it. If the blood pressure drops off so low that you have a hard time hearing it, we may have to do what's called a palpated blood pressure. We use a blood pressure cuff without a stethoscope, and we feel for a pulse while we do that, and we'll go over that in a minute. The third way would be just to feel for a pulse. If you feel for a pulse in different locations, that can give you an idea of what the blood pressure or the minimum blood pressure may be for this patient. So first off, let's go over the typical way with a blood pressure cuff and a stethoscope. So when we are taking a blood pressure, we have two pieces of equipment that we need to use. We have the actual blood pressure cuff, and then we have a stethoscope. We're going to use the stethoscope to listen to the pulse to determine what the pressure is that we're reading on the blood pressure cuff. So I'll run you through this and show you how to do it. So first off, I've got my blood pressure cuff here. Notice we have some artery markings. So we're gonna use those artery markings, and we're gonna make sure that that's in line with the artery. The artery that we're gonna be listening to is the brachial artery right here on the arm. So we're gonna slide it on the arm and line those up. So, I'll go ahead and slide this on. I'm gonna go up above the joint, leave a little bit of a gap there. That way we have some room to put our stethoscope. I'm going to take the gauge here and I'm going to clip this onto a shirt or something so that it's up out of the way. I'll go ahead and put my stethoscope in my ears. Now I'm going to take the end of the stethoscope and I'm going to place that on the brachial artery. If you take the center of the arm here and you move just to the inside, that's about where the brachial artery is going to be. So I'm going to slide this directly on top, put firm pressure, and now I'm going to pump this up. I'm going to tighten off the valve here and I'm going to pump this up. I'm going to start at about 160. If you inflate this to 160 and you put your stethoscope down and you hear a bounding heart rate, you've got to go higher. You need to go higher than the pulse that you're hearing. So you've got to completely occlude that artery before you can actually start taking that blood pressure. So keep going, give it a couple more pumps, keep going up until you get to the point where you can no longer hear that pulse. Now I'm going to slowly back off on this dial. As it backs off, I'm going to listen for that top pressure. As soon as I hear the heartbeat, I'm going to go ahead and note that. And then I'm going to continue to listen to the heartbeat and continue to let pressure off. And then as soon as I stop hearing it, I'm going to note that pressure. That gives me my top pressure and my bottom pressure, which is my systolic and my diastolic. Once I have those two pressures, I put that together to form my blood pressure. So the second method we can use to obtain a blood pressure is the palpated method. So what this is you are palpating with your fingers a pulse. You're going to pump the blood pressure cuff up until that pulse disappears. You're going to crack the valve open and you're going to watch that needle as it goes down. And as soon as you feel that pulse again, that's your top number. That's your systolic. There's no way to get a bottom number or a diastolic number off of this. So you just go down, you hear it, that's your top number, and the way you'll write this is your top number with a line and then a P underneath. And the way you say that is, hey, I got a blood pressure of 120 over palp or 80 over palp or something like that. So two reasons you would have to do this is one, for some reason you don't have a stethoscope, but you have a blood pressure cuff. You can do that. You get the top number, it gives you an idea of what their blood pressure is. It's not completely accurate because you don't have that bottom number, but it's a pretty good indicator of what is going on with this patient based on what their blood pressure is. The second reason you may have to do this is if their blood pressure is so low, it's not getting a good swooshing noise past that blood pressure cuff, so you're having a hard time picking that up with a stethoscope. Sometimes this happens with patients that have a low blood pressure and you're in an ambulance bumping down the road, you have sirens going and you're having a hard time hearing exactly what's going on. Or you're in a noisy environment. So this is a method you can use. Put the blood pressure cuff on, feel for radial pulse, pump it up till you lose that pulse, back it off. As soon as you feel that pulse again, that's your top number. That's a palpated pulse. This last method we're going to use is just figuring out what the basic minimum pressure of this patient is without actually taking a full blood pressure. This is something that you would do more in a mass casualty or a critical incident, or you would do quickly. This is probably something you would do in the ABCs rather than in the actual full vital signs section of your assessment. So if you come to a patient, let's say they have severe blood loss and they're going to have a decreased blood pressure because of that blood loss. Some ways that you can figure out what their minimum blood pressure is by checking their pulse. So if we check their pulse in their radial artery, we can assume their systolic blood pressure is probably at least 80 to 90 on the bottom side. Now this varies based off patient's age, weight, size, everything else. So it's not a hard, fast rule. But if I go to a patient and I've got a good, strong radial pulse, I'm probably not too worried about their blood pressure being too low. If I go to a patient and I check that pulse and I've got a really weak radial pulse, I'm probably going to be a lot closer to that 80 to 90 on that systolic. So that would be a palpated pulse. We assume that we have about 80 or 90 over palp as a blood pressure. Now, as I move down, if I check for a femoral pulse, that's where the leg comes into the core. That's your femoral artery. If I check for a pulse there and I have a pulse present there, I know that I probably have at least a 70 to 80 systolic number on my blood pressure. As I move further, if I check a carotid pulse and I feel for a carotid pulse and I have a weak carotid pulse, that should tell me I probably have at least a 60 to 70 on my systolic blood pressure. That's a very low blood pressure. But the reason that we can feel those different pressures is the distance they are away from the heart. So the heart sits right here, so closest to the heart, I'm going to have more pressure. So as my pressure starts dropping, I'm still going to have a pulse here, but I may not have a pulse in my radius or in my femoral artery. So the closer we get to the heart, the better chance we have of getting that pulse with a low blood pressure. So 60 to 70, 70 to 80 with femoral, and then as we move out to the radial, we'll probably have 80 to 90. That's on the bottom side. So if we have a pulse of 110 over 70, and I check a carotid, I'm gonna have a carotid. It doesn't mean that I know exactly what that pressure is. It just tells me that at a minimum, I probably have at least this range of blood pressure for that patient.
So that concludes part 1 of our diagnostic series. In part 2, we're gonna go over some secondary assessments like pupils, glucose monitoring, breath sounds, and temperature of patients. And we're gonna talk about how to assess these and what they mean in these patients. So give us this video a like if you found it useful, leave us a comment below if you have any questions, and subscribe to the channel so you'll be alerted when there is a part 2. Stay vigilant, stay safe.